Good afternoon. I'm Joanna Wardlaw, Chair of the conference, and it's my great pleasure to welcome you to this ESOC TV session where we're going to be focusing on the patient perspective in stroke research and care and the work of the Stroke Alliance for Europe. So I'd first like to introduce my guest. First of all, co-chair Professor Peter Kelly from the University of Dublin, Dame Professor Caroline Watkins from the University of Lancashire, who's Professor of Stroke and Older People's Care, Professor Hanna Christensen from the University of Copenhagen in Denmark, and Dr. Rubina Ahmed, who is Head of Research and Policy at the Stroke Association in London and also representative for the Stroke Alliance for Europe. So thank you very much all for being here. It's a great pleasure. So first of all, we'd just like to hear a little bit more about what does the Stroke Alliance for Europe actually do? Can you tell us a bit more about it?
Yes, so the Stroke Alliance for Europe, we're essentially a membership organisation for stroke support organisations across Europe. The organisations we support tend to be formed of patients and carers and stroke survivors, but also professionals as well coming together. The work that we do is really about promoting the importance of stroke and raising the profile of stroke across Europe. Research is one of our key goals actually, and we support a number of EU projects across Europe. I think, you know, for us, without research you don't get the interventions and the innovations that you need for patients, so it's very important as patient support organisations that we support research, and we really advocate for patients being on research projects, that they co-create and their voices are heard as part of the project.
And do you work and engage with patient groups through these other organisations, or do SAFE have, if you like, direct interactions as well?
So we support the stroke support organisations who are then will work with the patients themselves directly. We do have patients on our board, for example, and our membership meeting is open to stroke survivors. So we have our next meeting in June, and there will be a number of stroke survivors at that meeting as well. But really, our primary aim is to promote, you know, the importance of stroke and to support those stroke support organisations. I work for the Stroke Association in the UK, which is why I'm a board member. Our charity is very, very big, but there are very, very small organisations who need that real support to, you know, kind of build their profile and to build the profile of stroke.
Mm-hmm. And obviously you deal with a wide range of different countries and I guess different languages.
Yes.
And a number of potential you know, communication difficulties.
Mm-hmm.
How does that work?
So we work primarily in English, of course, but for example, with the research projects, one of the things that we do is to provide funding to the stroke support organisations to translate the lay abstracts or the lay findings into their own languages. So we provide that support so they can disseminate the findings of the research. We also have health information in various languages as well, which we promote. You know, the Stroke Action Plan for Europe, we've translated that into a lot of different languages as well. So translations is one of the key things that we do.
Okay. So we're very fortunate to have in this session contributions from two patients who have been very involved in stroke research. So we'd have two short videos, and the first of those is an interview with Mr. Ewan Haig, who is a former naval architect. He's currently a participant representative on numerous steering committees and panels, and he's been involved in some of the ESO training activities. And he was interviewed recently in Edinburgh by a colleague of mine, Dr. Fergus Dubal, who's a stroke physician in Edinburgh. So he's going to talk to us a little bit about his experience of patient involvement in research and why he feels that that's a really important thing to be doing. So could we have the first video?
Hello, my name's Fergus Doval. I'm a stroke physician at the University of Edinburgh in the United Kingdom.
Hello, I'm Ewan Haig. I had a stroke nearly 7 years ago, from which I'm making a good recovery, and Fergus Duval has been my stroke consultant.
Thank you, Ewan. Just a couple of questions I'd like to ask you, if that's okay. And I suppose the first one is, why do you think it's important for us to actively involve patients in stroke research?
I think it's important because the patient has to be the focus of the therapist, and he has to benefit from the research work that is done. Maybe not directly, maybe not personally, or in fact most unlikely to benefit personally, but the patient group as a whole has to benefit in due course.
Thank you, Ewan, and I suppose it helps us to keep the research patient-centred and patient-focused. And just moving on from that, it's very easy for us to sit here and say involve patients and participants and lay members in research, but how can we as stroke researchers or stroke physicians actually go about doing this?
I think since the research has to be patient-centred in some way, it begins with talking to enough patients to form an opinion on what is needed and how to set about it.
And so access to clinics and access to hospitals where where patients are seen is important. But what else can we do beyond that, do you think?
Well, talking to patients is the key, I think. There are a variety of ways in which that can be done. It will be impossible to form a deep rapport with every patient. I think what is needed is enough discussion with enough patients to form a sort of collective rapport, if you like. And that might even be helped by forming patient action groups or by encouraging other groups to do so.
It can be quite intimidating to form action groups from scratch, and it's easier to speak with individual patients sometimes. And any other mechanisms that you've come across that we could be thinking about, or people we can approach?
There's at least a couple. Charities, I think, can be a useful way into patient groups if there are any. And in fact, charities might even be encouraged to lead the formation of patient groups like that. Depending on how each nation organises its health service, it's more than possible that there are active patient recovery groups. I myself have attended rehabilitation clinics and stroke exercise classes. That has proved very useful, and being able to marry in my movement exercises to knowledge about stroke has proved very much of a direct benefit.
Oh, fantastic. Thanks, Ewan. So being involved in some other groups, you can, or researchers can think about accessing other groups that are already exist. Fantastic, Ewan. That's been really helpful. And just one final point is, if researchers are thinking of doing participant involvement, it's important to fund it, which is where charities can come in and helping making sure it's properly sourced. So on which note, I'm going to say thank you very much, Ewan, and thank you.
And thank you, Fergus.
Well, thank you very much to both Ewan Haigh and Fergus Dubal for recording that video. That was really helpful. Peter.
Yeah, so some great ideas there from Ewan. Action groups, talking to patients, the benefit of getting involved in recovery after stroke, and connecting with other patients who've had similar experiences. Caroline, any ideas, views from yourself about how patients and doctors can work more closely together to conduct meaningful stroke research?
Yeah, I mean, I think one of the things that we don't often do with patients and carers is talk about what we have good evidence for and what we really don't have very good evidence for. So we don't tell them what we don't know. And in telling them what we don't know, we have to think of ways of getting that information across. Because how other way are they supposed to understand what research evidence is missing? It's a bit of a funny thing. So they can talk very clearly about their experience and what what should have been different. And depending on where they are in their pathway since their stroke, they will tell you different things. So that's why it's always important to get people who are very close to the part of the pathway that you're actually talking about. So asking somebody many years later about priorities for research in the acute stroke unit mightn't be very appropriate. So to some extent, we have to think about, what area of research we're looking at. We have to think about the existing evidence and how we share that in a transparent and clear way with patients and carers. And we also have to think about how we share that between ourselves, between clinicians, between academics, because I think some evidence summaries that we get aren't exactly short. So we can have huge tomes of information, 40-odd pages long. And one of the things that one of my colleagues, Andy Clegg at University of Central Lancashire does, is he has a team of people who work collaboratively with patients and carers and clinicians, people, at the sharp end, and go through some of these very lengthy systematic reviews and think how they can summarise that into something that's more manageable. So something perhaps 4 or 5 pages, and then we turn those shorter versions with clear messages into a easy access version that's more accessible for patients and carers. And then I think that gives patients and carers that you're involving in things more of a chance to make a well-informed contribution to priority setting.
Yeah, so some great ideas there. So the idea of almost like a patient assembly to discuss and brainstorm about what's important to them based on their experiences at different parts of the pathway, and then written information as well to help to digest some of the information. What about the idea of patients being involved as co-designers of studies, or being involved very early on in the design of individual studies? What are your thoughts on that?
I mean, absolutely, that's absolutely fundamental to set the priority, to be then involved from the get-go in discussing not just what is done, but how it's done, so they can give you advice about how to put the ideas across, the questions to ask, how to lay out things. I was thinking about Rubina saying about translating things into written formats, and one of the things that we've done is actually translate things into verbal formats, because often people, although they might speak another language, they don't necessarily read it, so they might just need verbal things. So we've done messages in Hindi, for instance, for South Asian communities, with English subtitles, because that's what they told us, whether they spoke, Gujarati or Urdu or whatever. They said that this was sort of a more universal language, and that was the best way to do it. So we have to take those messages on board. It's more difficult, perhaps, but actually you have to have the right way to do it, and you need to be advised by those people themselves, because we don't know.
Completely agree.
I wonder if that's a good moment just to hear about some of the Stroke Association's work with the patient panels and try and encourage where patients want to come forward and participate.
Absolutely. So at the Stroke Association, we also fund research, and for us, patients are a core part of that decision-making process. So we have a patient panel called Stroke Voices in Research. It's open to any patient, and they approach us, and we support them through that process, because as a patient, it's often quite daunting to have your voice amongst clinicians and professionals, but their voice is just as valid as anybody else in that room. So to really support them through that process of making a contribution, they look at the applications. We ensure that our applications are written in a lay format that they can understand, and that's some of the things that they will comment on, and things like, as Caroline said, acceptability for the patients around some of that research, whether it's relevant to them. Those are all really important contributions that they can make. And actually last year we ran something called the James Lind Alliance Priority Setting Partnership, which was, you know, a massive exercise that had over 1,400 people come forward and say what their priorities were for stroke research. And it's a very robust methodological process, but actually it allowed us to say, as funders, we want to prioritise the research that matters to patients. And I think that's the challenge back out to clinicians and researchers, is to fund research, you know, to come up with the research ideas that will make a difference to people's outcomes.
Yeah.
So I wonder if at this point maybe it would be a good time to hear our second patient interview. So we're very grateful to Mr. Martin Assen-Wright, who is a communication advisor at the Norwegian Thyroid Association, who was recently interviewed by Dr. Else Sandset in Oslo in Norway. Martin is now a member of Norwegian patient advocacy groups as well. He's someone who had a stroke at quite a young age when he had young children, and so he has a slightly different perspective. So if we could have the second video now, that would be great. Thank you.
Hi, my name is Else Sandset. I'm a stroke neurologist from Oslo. Today, I'm accompanied with Mr. Martin Assen-Wright, who is also from Oslo and who has suffered a stroke. Hello, Martin.
Hello, Elsa.
Can you first tell me a bit about yourself, Martin?
Yes, I'm a 46-year-old Norwegian father of two who had a stroke 5 years ago when my oldest son was almost 3 years old.
So, Martin, you had a stroke at a relatively young age. Can you tell me a bit about how this affected your family life?
After the stroke, I had fatigue and cognitive outcomes, such as more anger and frustration and loss of patience. And I wasn't able to be the father that I wanted to be, and my son was exposed from a changed behavior. And he wanted me just to be a kind dad who had patience with him and wanted to play, just to be a dad. And sometimes I was that dad, but not always. I could also be this new father who was angry, stressful and frustrated and had to sleep during daytime on the weekends.
So Martin, your story, and we have talked about this before, has really enlightened me as a doctor and has changed my practice in a way, taking more care of both the family and also the children. What are your thoughts about how these issues and the things you experience, how can we as healthcare professionals better care for you in the situation you were in?
I think this is a matter of dialogue between the stroke patient, the caretaker, and the healthcare professionals, and call it early intervention at the hospital, because most of the rehabilitation takes place in the home, and therefore I think it's absolutely crucial that the healthcare professionals involve the partner or the spouse at the hospital, or maybe also the children, if they're old enough, in the dialogue. And if the caretakers, both the parent and the children, have more knowledge to what to become and what to expect in everyday life, and also how it might affect the children, they have more information and they are better positioned to the new everyday life.
I think this is an important point, Martin, and also that we increasingly talk to both the spouse, the partner, and the children. So Martin, you were in the situation where you walked out of the hospital, and when we look at you now, it's very difficult to understand that you have had a stroke. How do you think your experiences can improve our research? And why do you think it's important that we include you as a young patient when we plan our research?
I think it's very important because we are your primary source. And young stroke patients, they usually go to work and they maybe have a family and children, and so that's a different kind of view or different kind of story to it. And so please invite us to join. We know how it is, and we can tell you.
Thank you very much, Martin. And I think you highlight a very important point that it's not just lifting the arms or legs or having an asymmetry in the face that is important. We also need to take into account more hidden effects of stroke, such as on cognition and change in personality. So thank you very much, Martin. It's been great talking to you, and thank you very much for joining our meeting today.
Thank you.
So really moving and powerful interview there with Martin, I think, and it really gets me thinking about how we can do better as both professionals and patients and patient advocates to advocate better to government for improved stroke services and improved funding for stroke research. And I'd just like to put that out to the entire panel. Maybe Hannah, as our SAP-E lead, maybe you could give us your thoughts first on that, please.
My thoughts are that from my experience with from the Action Plan for Stroke in Europe, that had we only been the healthcare professionals, had we not been the healthcare professionals and the patients together, we would not have achieved what we have achieved at this point. We can go out as healthcare professionals saying that we recommend something, but the patients, they have another possibility. You can go out and say, we demand it, because this is something you need in your lives. This is something we think with our heads would be a good idea. So, and then secondly, we have an excellent collaboration with SAFE. So you have collaborated, you have contributed more to this project than just by bringing forward the patient perspective. So that's my impression.
Rubina, what
no, and I think for SAFE, you know, what we've set out in SAP-E are very reasonable recommendations around what we believe all patients across Europe should receive, from prevention through to rehabilitation and life after stroke. Our demands aren't, they're not out there. That's what we think should be a minimum standard. And so it's really important for us as, stroke support organisations across Europe to advocate for our patients and to give them a voice. We know that stroke research is very underfunded compared to other types of, research such as cancer. We know that stroke often doesn't get the visibility or priority at government level. And what it's really useful to do is when you have those conversations with government, I can go in as a professional or as a clinician, but it's the patients that make the real difference in those conversations. When they talk about their experience and bring it to life, that's what really pulls at the heartstrings and gets the politicians thinking about what they need to do.
Right. I couldn't agree more. I mean, one thing I sometimes wonder, I'm in the fortunate position to know lots of stroke physicians and very many stroke patients, and sometimes I wonder if we're too nice, if we don't get tough enough and hard enough in our advocacy messages. And I just wonder, what people think about that. Obviously we need to be positive with bringing forward solutions, but I think we shouldn't be scared to call out where we see people not stepping up to the mark and sometimes getting a bit cross about these things and angry. What do you think, Caroline? You have a lot of experience. Maybe
getting cross.
There's a place for it sometimes, I think.
Yeah, I think we have to get trust. I mean, to some extent, if you don't show how emotionally engaged you are in making changes, then people don't really take you seriously. So I think somehow finding a way of bringing the emotion out, I suppose, in politicians is probably what we need to do. We need to find those stories that really strike home to them. We need to find out, I don't know, maybe we could do with having some fly on the wall to see what their lives are like, and therefore to find people with stories that would really tap into the things that would be meaningful to them.
That's right. Yeah.
I think, you know, it's very hard when you only see people in a clinical environment to actually think about what their lives are like when they're at home and with their family and what have you. And obviously we've had some examples of those things. But I think even if staff themselves just work in the hospital all the time and never go out to people's houses and see what they have to deal with in their lives, then they too won't see people and engage in that whole emotional experience of it, because it will just be another job on the list. And I truly don't believe that people in stroke care think like that. But I think unless you actually see it firsthand, it's really quite difficult to get your head around it.
That's right, and very powerful, I think. I think ultimately people connect on a human level, don't they?
Yeah.
You know, we spend a lot of time reviewing data, etc. But if we really want to make step changes, it's done on a human level, which is why the patient stories are so powerful. Ultimately, sometimes the best thing we can do is sit back and let our patients speak.
Yeah.
I think you're right. I mean, one of, I think, the things that we don't do as well as we could do, and that's something maybe the physician side of things can do as well, is to shout louder. I think I used the analogy the other day about, you know, if human babies didn't cry, the human race would have died out, you know, millennia ago. You can't ignore a crying baby. It's very difficult to ignore somebody who's having a heart attack and has severe chest pain. Somebody who has a stroke, frequently they can't speak and they can't shout. And so maybe we as individuals and then collectively within our organisations in cities and in countries need to push harder. I mean, one thing I just wanted to come back to in the last few minutes, you know, we now have a number of tools like, you know, through SAFE and the SAPE. How can people feel confident to do more about, you know, going to their local politician or going to their local government? I mean, stroke is so common that every single politician must somewhere know somebody who's been affected by stroke. What can we do more to have more impact?
You know, with my policy hat on, I would say actually the first step is the evidence base. So we've got really strong evidence-based therapies in stroke, and now we've also got the stroke services tracker, hopefully, which will provide actually data around the inequity. And I think inequity really gets politicians that one country is better at something than them, and actually that's a strong evidence to take. You know, this country is doing better in this area than us. What are we doing to meet the patient needs for our communities as well? And I think, you know, it's as you said, it's the community as a stroke community with the professionals, all of us involved across the whole stroke pathway with the patients going together and really advocating for stroke. But we've got a lot of evidence to support our arguments. So, you know, and I think we just need to become better at making the case and really pulling on that narrative.
And I think we need to be clear as healthcare professionals too, because for us it is also emotional when we see disparities, when we see patients that are discharged to something which we think is insufficient. So we should allow ourselves to involve our feelings a little bit in what we do. And say this is simply not okay. We should use the channels that we have, and we should use, as you say, the instruments we have from Action Plan from Stroke to bring forward where the problems are and who are doing it better, taking the experiences from countries that are doing better.
Okay, and Hannah, I think you're about to chair a session looking at SAPE and where it's implementing well, where there are barriers, because it'll be different things in different countries,
yes.
I guess. So
yes.
sharing that kind of experience
yes.
can be really powerful
yes.
as well. So I think at that point we probably ought to close, but I would really like to thank all of the guests here, and I would particularly like to thank Mr. Ewan Haig and Mr. Martin Assenwright, and Fergus Dubal and Elsa Sanset, respectively, for those interviews. They were really powerful, and we really appreciate your input. And I guess we would all just, as strongly as possible, encourage everybody at any level in stroke research or stroke care to try and take the opportunity to engage in the wider dialogue where possible with patients at all stages.
Absolutely.
Yeah.
Hear, hear.
Thank you.